that are upcoming. And if you want to get your CE credits, so you do get CE credits for attending these webinars, then you go here, so to certificates. To apply for the certificate, the webinar must be watched through here, obviously, and then go to the ADA cert, click on refresh, and you'll download your certificate. Now, please feel free to ask questions during Ivan's webinar using the chat function. We won't ask it during the webinar, but at the end, I will read them all out to Ivan. There's usually a huge amount of questions. So unfortunately, we may not get to all of the questions and I'll have to pick the most commonly asked questions. Apologies if we don't get to your individual question. All right, so here we go. Today's topic is a big one. Firstly, I wanted to thank Professor Darby for taking time out of his very busy schedule to give us this webinar, because it's a doozy, a big topic to cover. So Professor Ivan Darby is head of periodontics at Melbourne Dental School. He qualified with a Bachelor of Dental Surgery in 1991 and a PhD in the year 2000 from the University of Glasgow, and was awarded the Fellowship of the Royal Academy of Dental Surgeons in Perio in 2006. Since 2001, Ivan has been in Melbourne following 8 years in general practice and then 4 years of perio training. He's running the postgraduate periodontics program at Melbourne Uni for, I think, 15 years now, maybe longer. An active researcher with an interest in the management of the alveolar ridge in the aesthetic zone, which comes in handy for tonight's lecture, and has published more than 100 papers, which is a huge amount for those of you who've tried to get any papers published. He works in both private and public as a specialist. In his spare time, he's editor-in-chief of the Australian Dental Journal and has just handed over the reins of the presidency of our Australian-New Zealand Academy of Periodontists. And as well as that, he's a senior fellow of the ITI. So now I hand over to you, Ivan. Thank you very much. And if you ask those questions in the chat function, and we'll look at them at the end.
Thanks, Jess. Sounds like I'm an overachiever there, but I actually don't have any spare time. So, okay, thank you all for joining us tonight. I think this is the third title for this topic that we've had. So we kind of ended up in soft tissue management around implants before, during, and post implant patients. So this is just a little before we start. I just also need to add something in that I need to possibly apologize for my 11-year-old and 8-year-old running in just to see what's going in, and it will also be quite noisy because it's going to be bedtime, but we'll see how we go. So what I thought about was to talk about aesthetics, but take a slightly different point of view from it. And I don't know if you saw the emails that have come out recently talk about the timeline, the lifetime of an implant, rather than just going through the standard view. How should we do this? Then you do this. Then take a little bit of a sideways look, possibly a little bit of a negative look, but we'll see how we go. So you've had plenty of time to read what is a good aesthetic outcome, and this pretty much applies to what we want to do in the aesthetic zone. So whatever the patient shows when they smile. So if it's me, you don't show anything. If it's Julia Roberts, you show 1.7 to 2.7. So this is what we're looking for. So these are two cases. So if we go back and look at those criteria, which of those is a good aesthetic outcome? Now, the purists among you would probably say neither of them, although I would suggest to you the top one's better than the bottom one. They are actually both my cases. Now, I do not make any claims to be a fantastic clinician, but I will be popping a few cases of mine in there, and we'll go through why these cases ended up this way. I am not responsible for the restoration. I just do the surgery. Okay, so if we look at these, then I think you'd probably agree the top one's more likely to meet their criteria than the bottom. But how did we get there? And how could I have improved the situation? So, interestingly, putting this talk together, which I spent most of Monday doing, I was actually looking at, well, what are the long-term outcomes of soft tissue management aesthetic outcomes around implants. And I came across this reasonably recent review that actually indicated there's very few studies, which I thought was actually quite surprising because, most of them on survival success, but now we're moving into patient-reported outcomes. So surely we'd want to know a little bit about how we feel and then how the patient feels. A lot of the studies that we looked at were basically just comparing clinicians or reasonably short term. The only one that we kind of came across was this one, a 10-year follow-up. It's essentially saying only 1 in 20 patients was not satisfied with the restoration. So this would suggest that actually we do quite a reasonable job. However, there's really no hard and fast data. We undertook a study in Melbourne, and I'm sorry this slide's a wee bit busy, looking at implant restoration versus the contralateral tooth. In this case, it's the 2-1. So the con is the contralateral, the implant tooth length is ITR implant mucosal margin, implant distal papilla, and implant mesial papilla. And we followed these up over a 3-year time period from restoration to 3 years, just to see if we could see if there's any changes. And if you look, and this is just a summary of the tooth length, the mucosal margins, the papillas, from the 3 different time points, and then the bottom line is just the baseline to 3 years. What we actually found is that essentially once the restoration's on, certainly within this 3-year time period, and in this study, things are actually pretty stable, which bodes well. But I'm going to be a little bit pessimistic about outcomes, possibly a little bit too negative, but bear in mind that majority of implant outcomes are actually pretty good, and the patients are probably a lot happier with the outcomes than all of us. Okay, so this is the life cycle of a female from being a child all the way through to a Zimmer frame. Something we've all got to look forward to is a Zimmer frame. So what I thought I'd do is be a little bit tongue-in-cheek and then just put the life cycle of an implant against this table. So you can see extraction, placement, uncovering, then you've got restoration, and then essentially adulthood is the implant in function. And then I've been a little bit, I say, pessimistic, just saying here's a little bit of the disease in old age, and then when it gets really old, the implant falls out, which obviously is where it doesn't really happen that often. But that's just to try to put it into context of what the twist that I'm taking on things tonight. So looking at the life cycle of an implant. So what I've done here is I've just put together the 7 ages of implant soft tissue management. So this is before you start: pre-placement, placement, healing phase, crown insertion, and function. And yes, I do know there's 7, but you're just going to have to wait till the end to see what the 7th age actually is. So I just want to spend a wee bit of time on each one of these, just so you can just go through them. Okay, so we're looking at childhood. So preparing for adult life, really getting things ready to make sure the best outcome and can function through the patient's life. So age number 1 is preparation. I think I once heard a quote that everything goes wrong if you don't plan properly. So we need to have an endpoint. What do we want things to look like? Now, I'm not talking 5 years, 10 years. I'm thinking 10, 15, 20 years. So how are you going to manage the aesthetics over that time period? And as we've been doing implants, that our understanding of how things mature, change has evolved with time. You're now getting clinicians, showing cases that they've been monitoring for 15 and 20 years and then showing the changes. And it's really quite interesting in that you've now probably got to modify what you're doing. So, I mean, this is really a no-brainer, is thorough assessment, preparation, looking at surgical technique, understanding biology, using guides, grafting, how do you keep your restoration on, cleaning and recall? So I think the first stage that you got is really getting ready for things to happen. And I think we're all well aware of that, and I suspect all of us do that pretty well at the moment. And I don't need to labor the points here in terms of the site assessment. I mean, we're obviously focusing on the aesthetic zone. Then what have you got to work with? What do you need to do to make it work for the patient? The basic assessments. And then, what is the ridge shape and contour? What do the patients show? I mean, it's a case like myself, I don't show the soft tissues, so probably don't need to be focused too as much on the soft tissues as somebody that would have a smile line. Contour, can you achieve something that looks natural? I mean, if you think about a perio patient, they're in the back foot from day one. So what can you achieve? Papilla I've got in there is, a papilla, especially the distal one, is always difficult to achieve. And then phenotype. Again, no one really talks about the effect of phenotype on outcomes. I mean, you'd think that a thin phenotype, more likely to get a recession or more likely to get components throwing through. And then you may want to increase the thickness of it. That's usually one reason why you would consider doing a tissue graft. And then obviously the reason for extraction, the reason how that's going to affect whether there's pathology, what stage the socket's healing at. So that all directly relates to what you're then going to do with the patient and then managing the outcome. So I would suggest that, good planning sets the scene for the patient's life. Okay, so age number 2 is pre-placement. So I was going to try to tie this in with the ages of the children, the stages. So this would be pre-placement. So this would essentially be getting the nursery room ready, buying all your nappies and whatever you'd like to do. So you really have two choices here. One is that you've got an existing tooth that you need to manage. So the consideration then is, should I graft around the tooth? Well, to try to improve the soft tissues. To me, that's a bit daft, really, because you can manage this grafting as part of your implant procedure. Covering up these soft tissues or these root recessions isn't really going to help in the long run, because that's something you could do with healing, grafting during the procedure. So that's something on a necessary procedure that's probably not going to be that more effective than what you're going to do. You've then got your healed site, and then obviously you've got to work out whether there's a hard or soft tissue or both, and then how are you going to manage this. I'm a great believer, and I think many people are, that the soft tissue is essentially held in place primarily by the bone. I mean, yes, there's things we can do to manipulate the soft tissue, but it's primarily the bone. So I'm a great believer in getting the bone where I want it to be. Now, I don't want to be too academic about this lecture in terms of being pedantic and going through all the different graft materials. There's a lot on the market, as you're probably well aware. Autogenous or autologous bone and DBBM, deproteinized bovine bone mineral, are probably the two most common ones. And they're the ones I'm going to spend a little bit more time on tonight. Certainly the much better researched ones, and we're very clear about their outcomes. So obviously they're the grafts, and you obviously have to pick your type of graft depending on your defect. So this can be simultaneous, or in terms of pre-placement, preparing the site, you might consider some staged augmentations. So really, you can't fit the implant in the correct position, so you want to augment it. So this is a case in the middle where there isn't enough ridge width, and then this is a case of mine where we sent the patient to Max-Fax surgeon to have a block placed, and this worked really well. As I'm sure you're aware, if you want to do some vertical augmentation, you need a solid block, whereas a particulate graft doesn't really work. In gaining some vertical height, it works much better horizontally, but there is a limit to what you can achieve. So this would obviously add to the time. And then the other side of that is, if you don't want to use patient bone, is then your xenograft material. And this is a case, so this is one of my colleagues, Dr. Luan No. So this is a 3D CAD/CAM manufactured framework where it's being used just to augment the ridge. So from the CBCT scans, the framework's made. It's mixed with this case into a little bit of human bone and some DBBM, and then that's put into the framework. And then essentially the framework's placed, screwed in a little bit more, is packed in it to fill all the defects, and then a membrane's put over, it's sutured up, and then this is just a couple of weeks later at the post-op, and you can see the bone volume. I don't think the cold sore in the patient's lip is related to actually the surgery itself. I suspect it's just a incidental finding. So this works quite well. This is an emerging technique, but I think instead of causing extra morbidity in the patient, then this is something that we could consider using, and it's certainly a great way, or both ways are, of doing a staged augmentation. You've got to remember also that staged augmentation will add about 6 to 8 months onto the treatment time, but I would suggest to you that if you get a better long-term aesthetic result, you're thinking 15, 20 years, and an extra 6 months is worth waiting for. Okay, so soft tissue grafts, in terms of site preparation, you may just feel that you want to do some ridge contour augmentation with a graft. So as you're well aware from the patient, so if you look at the top image in the middle, the one with the tooth, that's a free gingival graft around. It's not one of my cases. On the top right is a subepithelial connective tissue graft used for expansion of the ridge. Possibly not my choice, given that there's probably a bony deficit there as well. The row in the middle is a kind of cadaveric graft material. And then the bottom row is a expanded porcine collagen matrix to improve contours. So all of these seem to work reasonably well. Connective tissue grafts, always on free gingival grafts, are well established in the peri-literature. As you're well aware, with the free gingival graft, the color match can be problematic. So the connective tissue graft is probably the way to go. And if you don't want to use human part of the patient, then probably xenogenic graft and the expanded porcine collagen matrix seems to be the one that's currently in favor. Okay, so the other option in terms of pre-placement is how are you going to manage the extraction? Obviously, I know be gentle, everybody knows that. And then you've got a series of choices that you then have to make, and that's your personal opinion. That comes down to the clinician. I'm not going to talk about socket shield. This is an aside, in Scottish law, as many of you know, I'm from Scotland, we have 3 jury outcomes: guilty, innocent, and not proven. Not proven essentially means there's not enough evidence to convict the person in the dock. In this case, I've used the not proven as because I'm not aware that there's sufficient evidence to go one way or the other. And that's not to say it doesn't work, but as far as I'm aware, the literature doesn't indicate too much about, does it work, doesn't it work, when you should use it, etc. So I'm just going to completely ignore that one and move on. The other thing I think we have to understand is post-healing, post-extraction healing. Now, we know that there is loss of volume, but 40% ridge reduction volume, up to 4 millimeters loss of height. But what's recently been shown is interesting is that not all sockets heal the same way. And if you have what you think is an attacked bony wall, it will heal, unfortunately, with recession. So as you can see here, if you look at the dimensions in terms of the masiofacial and the distal, so either side and then the midpoint, the facial always has the much greater loss. But interestingly, in this study, essentially showed that your initial dehiscence defect intact plates primarily ended up with a dehiscence is that whatever graft material you put into a socket, whether it's for socket grafting or immediate implant, will come into contact with the soft tissue, possibly resulting in loss of graft volume, but also definitely you're going to lose that buccal plate as well, particularly where you want it in the mid buccal. So in terms of grafting for implants, immediate implants, obviously you've got that marginal gap. There are different viewpoints on whether it works or not. This is a study that we did quite a few years ago in an animal model where we used a second incisor, submerged versus non-submerged. We just grafted up to the shoulder of the implant, and you can see in the middle image, you've got about 2 millimeters of that collar exposed just because of the resorption. So what does that mean? Well, it probably means there's going to be some loss of the soft tissue. Therefore, you're going to get some recession of that. And then if you look at the diagram on the right, so I know it's deliberately upside down so you can match it to the angulation of the implant. Doesn't matter whether you use submerged or non-submerged technique, you always lose that buccal plate. So that's an issue that we have. And then, one of the ITI consensuses about 15 years ago looked at the amount of recession that you get, and it was quite clear then that immediate implant placement, you get 1 in 5 of the implants will get greater than a millimeter of recession, which a millimeter then is something that the patient notices, and that becomes a problem. So suggestion is, if you're going to do immediate implant placement, you've got to use hard and soft tissue grafting. Interestingly, soft tissue graft, connective tissue graft provides better contour and thickness. So that's an additional benefit at 12 months, although there is no longer term data than this. And then obviously some form of grafting. And in this case, this is the porcine collagen matrix just to go on top of the particulate graft. And it works. But I would suggest to you it comes down to the carefully choosing the cases, but also the clinician's experience. And then if you look at the recent ITI consensus, this is essentially their criteria for immediate implant. So the type 1A is immediate placement and restoration. And you can quite clearly see there's some definite guidelines, and this will give you the most predictable outcome, which for me is what I want for my patients. I would quite freely admit I'm not the world's best clinician. I'm an average clinician. So I like to do things that are well within my capability of doing, and then get the patient a nice result for the patients. Okay, then that brings us around to socket grafting. Many of you know that I have a long history with socket grafting, having published my first paper over 15 years ago on this and a few reviews. It's no brainer. The best socket grafting material is the tooth. In this case, it's the 2-2. And you keep as long as possible, and you do it in relation to the timing of the implant placement. And I think that's a no-brainer now, and I think that comes in with your planning, except if you need to take the tooth out. So when we look at this case, this is Bryce, 23-year-old, whacked in the face in a nightclub. This is the loss of the damage of the socket and the buccal plate that you can see. That's the tooth. So an oblique fracture, which we probably quite naively decided to graft, just to see what we could get. Perhaps what we'd call heliodontics, but certainly worth a try here. Try to push that out and preserve as much bone as we possibly can. And you can use a whole load of materials, and there's a whole load of, if you're using a bone graft material, then you just have to put something on top and then a couple of stitches just to hold it in place. And there's a range of materials for both that you can use, with no one really having been shown to be any better. And this is a paper that we published about 15 years ago. And then if you look at the data, these are studies 20, 25 years ago, and essentially back then it was really just checking the changes, the starts of our understanding of ridge preservation. And essentially that if you look at the test group here, you can quite clearly see that ridge preservation socket grafting does make a big difference. Interestingly, then the question is, when should I do it? So the sites that take longer to heal, like molar sites, definitely. Sites that you think you're going to get a lot of resorption. But I would argue that if you're going to do the implant within 6 to 12 weeks, and there's a whole, well, maybe the patient's going to come back, maybe the cost. But if you know that, then do you actually need to graft? We also know that ridge preservation does provide better soft tissue outcomes. And these are just some cross sections of another canine model looking at the second incisor. So the image on the left with the green in it, that's the graft material, and then the image on the right is the ungrafted socket. And we quite clearly showed here that you had more volume maintenance with the grafting and in the mid buccal, which is really where you want it to be for the optimal aesthetic outcomes. Okay, so soft tissue outcomes. If you look, and there's a couple of papers on this. So this group, essentially, their outcomes with sufficient width and thickness for grafting. This outcome, again, an Italian group was looking at more keratinized tissue height. So you're ticking quite a few boxes here. And then this is a paper from myself and Stephen. And I'm sorry about a little bit of text, but it's really just saying that, if you're going to go in, your ridge preserve socket graft, and you're going in about 8 weeks, 8 to 10 weeks later, then you're going to have quite immature soft tissue that's still under the healing process. So maybe you don't want to be working with that tissue. Want to let it heal a little bit more. So in my experience, if you're going in at 6 to 8 weeks, you're placing the implant into immature bone. And if you've got to put the implant just within the socket, you're going to have issues with primary stability. And again, reinforcing what the literature says, you have more soft tissue, but it's not fully healed. So this is a site where they've been ridge preserved, and you can see the sockets with the graft material in there. Usually there's some soft tissue that needs to come off. So it's immature bone. Still getting some soft tissue healing, partially healed site. So again, maybe you don't want that indentation of the soft tissue, might affect aesthetic outcomes. Absence of the buccal plate. A graft does not stop the loss of the buccal plate, so you will still need to augment the site. And then if you do then put the implant in, that buccal wall can be really, really, really soft. So all of these can be counteracted by at the time of implant placement, avoiding extra cost or whatever to the patient, and probably reducing the length of time the patient's in the chair following the extraction. Okay, so age number 3. We're now ready to pop the implant in. Now I'm assuming here that we're talking about healed sites or partially healing sites. And this is the paradigm. So this is the Danny Boozer concept that I think is widely used, where you implant in autogenous bone on the exposed surface, bone graft material, low substitution rate that's going to maintain its contour, membrane to protect it, and submerged or semi-submerged healing. And that's the paradigm that was introduced about 20 years ago, and it works. Here's some clinical examples. You can see this is the case that I showed you at the start. So socket healing, implant in, and you can see the healing with the dehiscence. So you graft with autogenous bone up to the neck of the implant, and then you contour, augment, membrane, and close up. In this case, it's partially submerged healing. And then, 3 months, you can do your talk test and then send it off for restoration. And this is a predictable technique. And you can see in the middle picture in the bottom row that maintenance of that contour. I mean, that's absolutely fantastic. And that's what we need. And I'm going to come back and talk about that maintenance of the contour a little bit later on. The other thing that we have is what I've cheekily called the Goldilocks zones, where Danny said, okay, you need to put the implant in here, so you need that 2 millimeters of that buccal plate, which is probably an outdated concept because you don't get that circumferential remodeling of the bone anymore. But I think in terms of supporting the soft tissues and augmenting the contour of the ridge, then that's what we want. And notice I'm not talking about bone around the implant, I'm talking about aesthetics and the shape of the ridge, because we've gone past making the tooth look nice. We're now managing the soft tissues and the hard tissues. And then this is fairly straightforward. As you know, it counteracts the loss of the buccal plate, dehiscence or damaged socket walls, rebuilding the contour, and it can cover up the exposed implant surface. And in terms of long-term outcomes, again, Danny Bruiser really led this technique, and this is a 10-year-old paper where they had 20 implants, followed one implant, I think, was lost about 6 years. And the great thing about Danny is he puts all his data out so you can see the before and after images, and this is the 10 years, and I would say that they're all looking pretty good. And I'm not aware of too many other papers of different techniques with such a long follow-up, but so well documented. And interestingly, if I remember correctly, a couple of these patients were actually biopsied, and they showed that part of the reason why things are maintained is because you've still got those particles that don't resorb. Okay, so this is some unpublished research that we've undertaken at Melbourne. Again, what we have here is we're comparing an implant with the contralateral tooth, and we're looking at the areas of the ridge. So you've got the buccal, you've got the palatal, and then you've got the root. So you've got the pink for the buccal and the green for the palatal. And we're looking at the overall volume of them. And essentially, even though you graft, you lose about 10% of the volume. But if we then move on to a cross-sectional where you've got the tooth and the implant superimposed on each other, and then the millimeter marks, the implant shows IS, so the 1 millimeter is above, and then the increments go down. You've essentially, where you've got a negative number, is that it's in favor of the implant. So it quite clearly shows that if you do contour augmentation, that even though you lose volume overall, you really get that bone around the implant shoulder, and that's really where we want it for the best aesthetic outcomes. And this is data from patients who are up to 5 years. So, I think you can have some confidence in this technique that it will get the bone where you want, which means you're going to support the tissues. If you don't do enough grafting, well, you can get that concavity, that hollowing out, and you obviously, as you can see in the top right, then that can become an aesthetic issue. You get that discoloration. You may get componentry showing through. So really, we as clinicians, as part of our planning, should be trying to counteract the biology and then obviously build things up. So, the alveolus looks like the tooth was never extracted. And they say Danny's technique is reasonably simple and reproducible to do. The other thing was soft tissue grafting. This was very much in phase, certainly when I started placing implants about 20 years ago. But having done just a quick look at the literature, essentially nowadays, there seems to be very low quality evidence to provide recommendations of whether or not it should work. And as usual with these meta-analyses, it says further well-designed RCTs, larger sample sizes are covered. But it seems to have gone out of fashion with the favor being on the bone volume rather than the amount of soft tissue. So if you manage the bone, you'll get a nice soft tissue. And then just some more research from Melbourne. So this is the Pink Aesthetic Score. So this is one of a myriad of scores used to assess the outcomes of aesthetics. So this is the Furhauser one. And it's got 7 variables looking at the pupillas, the contour, the shape, the color, the position, the level, and all the points are scored 0 for poor, 1 for okay, and 2 for good. And then you add them up to get a score out of 14. So this is some work that comes from Stephen Chen's practice where we looked at all these different variables. So in the table, you've got the 7 variables, and you can see the median was 1 or 2. So the median total score was 11, which is fantastic. So anything kind of 9, 10 above is a great outcome. The reason why this slide is here is because some of these patients had connective tissue grafts, and all it did was increase the alveolar contour score. It did not make that much difference in the long run in terms of the aesthetic outcomes. Didn't really help with anything else. So yes, it's possible, but I would argue, well, what's the benefit when there are simpler things that you can do that are much more predictable and with less patient morbidity? Okay, back to this patient. So guess what happened here? Well, implants way too buccal. I think that's a no-brainer. That one is stuffed. Okay. Why? Poor planning, inexperience, lost the bearings. As you know, it's quite easy, even though you've got teeth either side, to kind of get lost where you are. Didn't use a guide. I can tell you now, this case was connective tissue graft, and it didn't make any difference. So with this one, I think there's a whole lots of things that added up, including a missing L in poor panning. Really, with this one, there's nothing you can do. We're going to come up to some grafting around implants at the end, but if the implant's in completely the wrong position, then start again. Okay, not particularly ideal for the patient, which is why it comes into planning and execution. I got no idea what happened to this patient because once the crown was and they didn't turn up, which is probably quite good because I would probably been quite depressed with the outcome. And then I don't think I need to put too much on this is managing the papilla. You're always going to get papilla loss, especially the distal and especially implants, next adjacent implants. And I'm not aware, and maybe that's something can come up in the chat that, are there ways of doing this? I've heard of all sorts of things about how you do this, and I've never been convinced that one is the magic cure, the panacea that we have. Okay, age number 4, post-placement healing phase. I looked in the literature and all that, and there's various different terminologies for this. The favorite one seems to be the healing phase. And essentially, there's a couple of time points you can do this. So one is if you've done a 2-stage procedure, you can do it uncovering. So on the left is a soft tissue subepithelial connective tissue graft done at the time of uncovering to thicken the soft tissue, provide more volume. And then the one on the right is actually a kind of like not an uncovering, but an intermediate time where they've raised the soft tissue, they've put a collagen matrix in there, and then closed it up, and then gone back in to do a third procedure. Connective tissue grafts have been around a very long time, and there's quite clear evidence that they work, certainly in the peri literature. The collagen matrix, again, evidence is emerging. Certainly, it seems to work well in people's hands and provides nice clinical outcomes. But again, there's the long-term evidence is accumulating. And then where you've got a single stage placement, again, you can do things with the flaps. In this case, it's a connective tissue graft, just tucked down the side, just to expand the tissue volume. I'm sure you could do that with many other materials. So this is another time point that you have. I would suggest to you that once the implant's in position and you've done your grafting, you're probably quite limited into much you actually actually surgery. So it's really going to be soft tissue manipulation with a limitation of what you can actually achieve. Okay, so H number 5, restoration, provisional or permanent. Now, I looked at this and I actually didn't really find any information about it. I found one study which I actually like to quote because this talks about socket grafting and ridge preservation. And I usually make some comments about the Belgians. Now, I love Belgians, but this group does some really good work, but occasionally ideas that you wouldn't really think of. So these did extraction of ridge preservation, implant placement, and then they did the connective tissue graft with the provisional crown placement, which sounds a little bit odd and counterintuitive. But they followed it up for 5 years, and they've got really good documentation. And then this is the case. I think this is 1, 3, and 5 years, and that's an excellent outcome. Now, I'm really uncomfortable about this because they don't manage the bone, and as I said to you at the start, I like bone, but this has worked really well. However, it would seem that there's not a lot of literature on this, so it's kind of possibly because it doesn't work too well. I mean, this is a very experienced group, so maybe that's why they got such good results, but it looks like it's not a technique to be recommended or suggested. I'm sure there's a few of you that it works very well in your hands, but for my reading of the literature, it doesn't really add up to something that we should be recommending for our patients. Right, so now we've kind of brought our implant up into function and then ready for life, which I've cheekily called adulthood. And obviously you can't change anything now. Whatever you've done is the way that you've left it for the rest of the time of the implant in the patient. Now, age number 6, I called this complications, but I should really probably just call it in function. And then one of the things that we mentioned, or something I mentioned earlier, is not enough grafting. Now, what I mean here is that even though you do have sufficient graft volume at the start, with maturation over time, that graft volume can actually diminish, especially if you've kind of under contour augmented. So you may end up with a defect like this that might need to be managed. And again, smiling, perhaps a little bit of recession, whatever. And there's certainly evidence out there that these can be managed. Very similar mucogingival techniques as you would use in perisurgery. Here, they are really just augmenting with a collagen matrix, I believe, but you could quite easily just do some bone augmentation there as well if you had a defect that was sufficient to actually get some bone info. So really, it's just management of the defect to try just to get some contour back. Now, I'm going to go through towards the end of it what I think are the time points where it's going to work. I think as you get further on into the implant's life, then the more complicated it gets to get a nice result. So you're dealing with a healed site, you're dealing with poor vascularity, you've probably got a little bit of recession, lack of papilla. So I think you're quite limited into what you can do as a result of maturation, or perhaps not doing enough at the time of placement. That said, I mean, as you're well aware, you can get recession following implant placement, and this one taken from Perio 2000, as you can see. I would suggest to you that the implant's placed in the wrong position to start off with, but also there's been some occlusion over time. So what they've done here is they've actually removed the crown and gone back to the implant and a cover screw. And I would suggest to you that this is actually a really good way of doing things. Just let things heal up, let the soft tissue cover it, give yourself a little bit more soft tissue volume on the ridge, and then go in and augment the site. Now, again, I think you have to pick your cases carefully. Again, I would suggest to you perhaps need to look at whether or not that implant needs to be removed. And given that it's much easier to remove implants these days, I would perhaps suggest to you that we do it more often. But I'm going to come to that at the end. A large graft, close it up, and then let it heal up, and you get quite a nice result. So it does seem to be possible. I would suggest to you that it's much more complex, and then the predictability of this gets a lot less. So if you're looking at a good outcome for your patient, you kind of want to make sure you start, get a good outcome before you go into that adulthood phase. And then this is just another case where, again, I suspect the implant's in the wrong position, but in this case, they've used a connective tissue graft and some mucogingival surgery just to bring the cronally advance all the soft tissue around a number of teeth actually, and with a graft. And again, that worked quite well. But you're now getting into some really tricky, fine mucogingival surgery techniques. So, as I said to you, it's getting a little bit more tricky. And then obviously you've got the vascularity. You've got a connective tissue graft. So it's always a race between cells growing in it to keep it vital, and then the graft breaking down. So you have to think about, well, where's the blood supply going to come from? And then this is one I just picked up as well. So this is this is what I would call herodontics, where they've done I think they called it a lateral pouch grafting technique, which I don't quite understand what it is, but you can see you're getting really into the weird and the wonderful. Two poorly placed implants, no buccal bone, and really they've just tried to bring some soft tissue down. These cases, again, probably goes back to planning and placement, and what we're really trying to do is rescue a compromised result. But it is possible to graft around implants and do it quite successfully, though you can't consider it the same way as you would consider grafting around a tooth, because the anatomy and the tissues are completely different. Okay, now our friend periimplantitis. It's interesting. I mean, Jess said I'd run the postgrad program for 15 years. I stopped for 5 years, and now I'm going to take over again. In that time, we've had transition from just teaching postgrads to do implant surgery to management of periimplantitis. And a lot of our practices now, we see quite a lot of patients with periimplantitis. In terms of the aesthetic outcomes, just looking through the literature, there's not a lot of it. We know a lot about the defects, we know a lot about the graft, and we know how to manage we know what we can use to manage the surface, but our outcomes are still pretty poor. So this is a case here. Now, you can see in the 1-1 in the mid buccal, you've got that discoloration of the soft tissue, which indicates there's something there. And when I was putting in this talk together, I was thinking, well, maybe we should have just left it. The best aesthetic outcome. Okay, so it's got a probing depth of 11 millimeters, but it looks good. Because we know that as soon as we go in and open things up, and this is a cemented restoration, I would advocate that you always take the restoration off, especially if you think you're going to get a little bit of recession, because then you can just let it heal and use some of the gingiva mucosa on the crest to augment things. And then we grafted, and then reasonably fancy mattress suture interrupt. So just try to pull down slightly the tissues to stop it from receding, but you're going to get that recession whether you like it or not. And I'm not aware of particularly any techniques or any literature out there that says how do you minimize recession around periimplantitis defects. Always seems that you're going to get a little bit. Okay, and then this is another case that was done surgically as well. Just looking at this one again, I was thinking I was putting this talk together. Well, maybe we can use mucogingival techniques here as well. Just put a connective tissue graft in or whatever. So with this case, the implant was placed. It was done as 2-stage. They had periimplantitis surgery. They couldn't take the crown off, and then you're going to go in and do a third surgical procedure in scar tissue, not that very vascular, on a denuded implant surface. So what is going to be the benefit? What's going to be the result? I would suggest to you, once you're at this stage, you're actually not going to achieve that much. Okay. And we know that papillas, we just can't get papillas back. It's really tricky to get a papilla. So I would suggest to you then that, well, maybe it's a compromised result. Yeah, you're starting to show the abutment. But if it's healthy, then, as a colleague of mine once said, better the tooth longer than the tooth no longer. Or maybe we should say better the implant longer than the implant no longer. Because it's there, it's in function. There is some kind of aesthetics associated with it. Just have to accept that it's compromised, and that may be what happened. Okay, so this is Paul. Paul was hit in the face by a surfboard and knocked out two his central incisors, and they were restored with implants. The implant on the left, the first one, failed, and then it was replaced. Both implants are cemented restorations. Both implants have different abutments and different materials. Both of them had similar probing depth, and as you can see, quite marked circumferential defects. So you know what's going to happen here. You've got a mix of exposed implant surface, and you've got a mix of the defect. So you're going to graft up to the level of the defect, and then you can try cruelly advancing whatever. So the image on the top in the middle is the graft, then the image on the right is post-op, and then the image is in the middle on the left is 6 months, and then the image on the bottom is now 2 years. So we can see we've had some maturation of tissue. It's taken quite some time, but you can see, there's been some recession. We knew we were going to lose tissue height. We're always going to lose that papilla. So I don't know, and I've not heard of anybody saying, okay, this is a way that we can predictably get the papilla back. I'm sure if you could take the implant crowns off, that would be great. But in this case, we're stuck. And I'm not sure connective tissue grafts or something like that would actually provide any additional benefit. But, maybe somebody can provide me with some advice about how I should approach this case. An issue. Patient's happy. He doesn't show it. There was a little bit of sibilance, hissing with S's initially, but now he's got great access and does a pretty good job of keeping it clean. Okay, so just moving into the end of the talk, we're now in the last stage. So, this could be the ice age or the last stage, but this is number 7 that I didn't include at the start. We need to take more implants out. And for those of you, when I put the extraction picture up, this was one of the extraction sites that I had. This is an implant that's been removed. And I think, and I've said this for quite a few years, in terms of managing the aesthetics, there's some things that we just can't do. Let's just give up and start again. So when are you going to take the implants out? 50% bone loss, starting to get some recession. But a colleague of mine, when we were talking about this, turned around and said, Ivan, what are the consequences of removing an implant? How much bone's going to be left? How much grafting? Can you put the implant in? What's the age of the patient? Is it better just to have a compromised implant in a site that if you take it out, you're not going to be able to get one in? So maybe then we shouldn't worry about the appearance too much. That said, where the implant's in completely the wrong position, yeah, take it out and then start again. But again, what's in the way and what's going to be left. As I said, where are you going to get the bone? Where are you going to get the soft tissue? And then some patients actually starting again may provide a better aesthetic outcome than the surgery. So you go back to that patient of mine where I've given them 3 millimeters of recession. I've done a connective tissue graft. Back then, really hard to remove integrated implants. Now with the implant removal kits, for him, be much better. Just take it out, put another one in the right position. So I think we need to be more proactive at this when we think about managing the aesthetics of it. Okay, so to finish off, how predictable are the statutory outcomes? So this is what I want to finish with. The image on the right is Bryce. So this was the gentleman whose tooth was knocked out in the pub with the collapse of the buccal plate completely. Now, I'm not particularly happy with the restoration. I think it's slightly too large and slightly the wrong color. But I'll let you decide whether or not this is a good outcome or not. I really just put it up there because it's one of the clearer photos I have. So these are our ages. And then when we're looking at what we can do in terms of the lifespan of the implant and then trying to maximize the aesthetics, I would say to you that starting planning, yes, you can get a good outcome. Pre-treatment, yes, you can get a good outcome. Placement, yes, you can get a good outcome. Healing phase, I think you're starting to be limited about what you can do. Crown insertion seems to be an absolute no-no, although the Belgians can manage it. In function, yeah, again, complexity is getting a little bit tricky. And then removal, obviously, if you have to take the implant out, then things may well be compromised. And with that, I'd like to finish off tonight. I hope that wasn't too quick. Thank you very much for your attention. I hope I've answered the question about soft tissue management aesthetics in the lifespan of an implant and then the complications that we are going to meet, hopefully not too often, as we go through our implant journey. So, Jess, back to you. I think I'm pretty much bang on time.
It's wonderful. You covered a lot in that time. So thank you. Have you got time for a few questions?
I do, yes. I think we've got, did I say 5 questions in the chat box?
We'll make it 6. All right. The first question was, do you ridge preserve all high aesthetic demand cases?
I went, to be honest with you, and I mean, this is my personal experience. Remember, I'm a day a week in private practice, so you could argue that I'm a pretend periodontist. I went through a phase of ridge preserving everything, and then found out it wasn't always necessary. But I would agree. I think with the high risk cases, then absolutely, you want everything, get everything in your favor as you possibly can, and there is some benefit documented in the literature that would help.
Okay, so you'd rather ridge preserve than regret not ridge preserving those cases.
Yep.
So you mentioned the contour augmentation. So I think this was in the implant placement section, so grafting around implant placement.
Yeah.
And you mentioned it was much more important to contour augmentation, so towards the coronal aspect rather than the apical aspect, because that's where you need the volume of bone. The question was, how far apical do you graft?
All the way up.
So you would consider contour augmentation all the way up the implant surface on the buccal aspect?
Yep. I mean, you've got to be realistic. So, I mean, when you put the implant in, you want primary stability. So you need an implant that's going to be stable. But you can still have, you can still have 2/3 to 3/4 of the implant surface exposed. And if you manage that properly with, your autogenous graft and then your BIOS, your DBBM on top of it, you can still get a pretty good result. So you're going to graft as much as you need. I thought a child was about to come in, sorry. But yeah, I think, you can do that. But I mean, the point about the contour augmentation is that it gets the bone where we want it and it stays there. Obviously, you're going to have to graft the whole surface, but with focuses on aesthetics. So the collar, the shoulder, the implants, the bit that you're going to see.
Okay, good answer. For Paul, the case Paul, you said it would be helpful to take the crowns off. Can you elaborate how this would help?
Is that a question for me? Or do I get to answer it? Okay. Look, I think firstly, access. I mean, for all of us have done surgery around implants that the crowns don't come off, access is a nightmare. I think healing's a lot better. I think also if you can submerge it, it gives you the extra soft tissue on the crest that you can then use. And it obviously, yeah, to me, it's a no-brainer. I mean,
Do you have
cemented
a preference
crowns.
for how you temporize then? So if you take the crowns off for healing, are you using just a Essex splint? Are you bonding teeth? What do you tend to do so that you can access that surgical site?
Whatever. I mean, I generally at the general dentist or the restorative dentist sort that one out. I mean, my instructions are don't have no pressure on the soft tissue. Essex is quite common. I like something personally. I think I'm quite lazy these days, and I don't like removing things and putting them back on. So, Essex is great.
We have a very good question here, one that I quite like. I think this is a good question. What do you think is the most common mistake inexperienced clinicians make when performing soft tissue augmentation? That's a good
Case
question.
selection. Case selection. I think you have to know your limits and you have to know which cases are going to work. I think also, I mean, it's very technique sensitive. I mean, you need to be reasonably skilled surgeon before you start doing it. I mean, it's one of the most trickiest things that we do. It requires a really fine touch. You know, it requires soft tissue handling, grafting, suturing. Usually, suturing is something like 6-0 sutures. So it's really technique sensitive. Really, you need a lot of experience. So I would suggest that it's not just something you turn around and one day and say, oh yeah, I'm going to start grafting. Well, you want to build up your surgical skills towards it and then pick your cases, but also knowing what technique to use and what materials are best for the cases that you do. But I would say build up your surgical experience before you start going into this. Get familiar, get comfortable with soft tissue manipulation before you start playing around with grafts.
Good advice. And lucky last, hello, Ivan. What alternatives do you suggest for autograft connective tissue in terms of material?
Okay, so I looked at this question and hope you weren't going to read this one. And Ritika, thanks for this curly question. All right, this is a perennial issue. I think. I mean, your connective tissue graft in itself, and go back to that inexperienced surgeon, is really difficult to harvest. I mean, you're looking at the palate, the vault of the palate, the thickness of the tissue, how much you want. So, I mean, you can try, just doing an incision and then filleting out the connective tissue. You can essentially just take a chunk out of the palate and then just remove the epithelium on it, and that's probably the easiest way of doing it. Or you can go to the tuberosity. I don't think we have graft materials, off-the-shelf graft materials that are as versatile as human graft materials at the moment, if you're going to leave them exposed to the oral cavity. There's certainly that porcine collagen matrix. A little bit technique sensitive, but again, it seems really easy, simple. It seems to be quite a reasonable replacement when you're using a submerged technique. But I think if you want to do anything open to the mouth, then the materials really aren't there. So I think we're working towards it, but I would still be a little bit hesitant to say, okay, use this one, cover up your recession techniques. I think all the materials at the moment have to be covered up. Now, I'm going to throw this one over to you, Jess, whether you agree with that or not, but that's where I'm sitting. Or maybe Marina and Angela, you're and Olivia, periodontists galore here. So I still think
I think their roles, but I agree with you. I think they're all very new materials in terms of the long-term outcome. So I think for all of us who've been periodontist for a little while, we're very comfortable harvesting soft tissue grafts. So it's very easy to use that as our go-to material. And I think there's certainly a place. I've had many patients who, for various reasons, would rather use, the graft that's not harvested from their palate. So I think there's certainly a place for those materials, but it's very easy to go to the palate. Once you do it a lot, it's a very easy and quick technique, once you've got it under your belt. Would you agree, my fellow osteology that are online?
Angeli said cover it up, so she's in agreement. But I think that, once you go back to that, once you've done it often, then it becomes easy. And I think that goes back to the question about inexperience. It's just, building up that experience, learning to be able to do those things and then getting the practice. And I think also it's keeping it going. You don't just do one every year, to be doing at least one a month or something, probably.
That's good. Well, that might draw it to a close. So, Ivan, thank you again for taking time out. Also, thank your kids for not coming in. I personally had to bribe mine. So I'm just going to quickly share with, if I can work out to do this. So to finish up, we have your slide. And then I'd like to invite everyone to our next webinar, which is not clipping or turning over. There we are. So, 13th of June at 7:30 Sydney time, we have Chris Ho presenting prosthodontic options in soft and hard tissue management, which we're all looking forward to. Thank you very much. I'll call it an end.